Good morning, everybody. Good afternoon, depending where you're connecting from. This is Alessandro Di Capo from UICC. Welcome to today's virtual dialogue, the third in our Cancer Beyond COVID-19 series. It's great that we expect a good number of people, so I'll do a brief introduction, waiting for people to get comfortable in our virtual room, and we're very exciting to have a panel of experts to address today's topic, which will culminate our series of 3 virtual dialogues. So today we'll be discussing strengthening the case for investment in cancer control. I'd like also to thank obviously our supporters and partners who have made this series possible: MSD, Novartis, Pfizer, and Canadian Partnership Against Cancer. So just a few ground rules. Probably you know all this by heart at the end of this year, so probably unnecessary to remind it, but just very quickly going through them. Make sure you are muted unless you'll be talking, and we hope many of you will be talking to us because this is a dialogue, so as well as our expert would like to hear from you as well. Feel free to keep your video on. We'd like to see where you're connecting from, obviously if the connection and the bandwidth allows, and do open the chat box and make full use of it throughout. So note your question, comments, even when the panelists are speaking, so we can pick them on those and weave them through the conversation. Just a quick look at what will be happening today. So there will be an expert-led discussion. So we'll have a setting the scene presentation by one of our guest speakers, a panel discussion with Q&A. And at the end, we also set aside some time to maybe move the focus onto the participants a little bit more, but we'll keep it flexible. We'll see how the conversation goes. We really like to get the most out of the speakers and make sure all your questions get answered. So we'll keep the timing flexible, but we should be finishing within an hour and a half. So I think with that, no, I almost forgot one thing. I wanted to quickly before I leave give the floor to our chair, Kerry Adams. I'm just going to stop sharing the screen and run a very, very quick poll. As we often do, we like to engage the audience as they come in. I think we have a good numbers in today. So, Sinead, could you please see if you can share the poll, because it seems to be disabled from my end. Otherwise, I'll pick it up later because that seems to have disappeared from my end. Otherwise, we'll...
Can you see the poll now? I think I'm sharing it.
Yes, we can see it.
Okay.
So maybe, Sinead, can you guide us through the poll, because I've lost a particular comment there. I don't see the poll at the moment on my screen. Thanks.
Okay. So the first question is focusing on financing. So how are essential cancer care services funded mostly in your country? Is it out-of-pocket expenditure, private health insurance, social health insurance, or government? There's other options of I don't know or other, which you can specify in the chat box. So let us know if the way your cancer services are funded is different to the options. Or if you have anything to add on this, feel free to share in the chat box. And then the second question, what is the impact of existing cancer care funding arrangements on people's care-seeking behaviors in your country? And we have a few options there as well. I might not read through all of them, but feel free to take a few minutes, read through them, and we'll go through. Will we go through the responses now, Alessandro, or do you want to wait?
Yeah, maybe we can quickly share the responses as soon as we have received a few, just to get us started. We're not going to comment, but just to set the scene to see where the people are coming from, what sorts of health financing model out there, and what impact are on cancer patients. Because in the end, this is why we're having this conversation, because health financing does impact how patients can access care.
Mm-hmm. So we have 20 people responded so far, about 50%. So a few more people can submit your answers. We still have time.
maybe we can share the responses now and see.
So for the first one, how essential cancer care services are funded, the majority, 70% of people, 71%, are social health insurance or government funded, which is good. There's a small percentage of out-of-pocket expenditure or private health insurance. And I know someone has said other as well, so please specify in the chat and let us know some other ways. And then the impact of existing cancer care funding arrangements. So the majority of people, 58%, said that costs are not a barrier in people's care-seeking behaviors, which is very good.
Fantastic. Thank you, Sinead, for the support. Suddenly my technical poll has disappeared. But without any further ado, let's move on to, let me give the floor to Carrie Adams, CEO, the Union for International Cancer Control. Carrie, the floor is yours.
Thank you very much. And I hope you can hear me, Alessandro. Excellent. Okay, thumbs up, we can start. Well, I've just been flicking through some names on the screen, and I'd like to say hello, Mary Gospodarovich, the ex-president of UICC and driver of cancer control around the world. Hi, Mary. I've seen Birgit Fluren from there as well. Hi, Birgit. How are you doing? And also I saw Therese from Alecta. So I'm sure we'll pick up some other names as well. But welcome to this particular dialogue on a very important subject, which is making the investment case for cancer control in all its aspects. And we have indeed got an amazing panel who I hope will be able to give you some ideas, views, and perspectives drawing on their own experience from their own sector, but also from their experience of what they've found talking to others in and around the world on the issue of making the investment case for such an important part of health. So we have, and I'll go through them very briefly and give a bio, then I'll hand over to Penny, who's going to do a short presentation. So we have Andrea Fagel. Andrea and I have known for a few years. She's the founder and executive director of the Health Finance Institute. She's a former health economist at OECD. She's a Harvard graduate, and she's based in Austria. She is Austrian, although she's been living in the USA and Canada in the past, and I first met her when she was in the USA. Thank you for joining us, Andrea. Then we have Anja Nischa, who's based in Vienna, Austria as well. So we have two from Vienna at the moment. Works at IAEA, which we're all aware of, does some fantastic work on radiotherapy. She's the head of resource mobilization in that business. And she's worked in Eastern Europe and countries and also in Southeast Asia. And she's also a recognized world leader in global health. We have Linda Gibbs. Linda, who's the oncology lead Central and Eastern Europe for Pfizer, based in Berlin, Germany, and a powerful advocate for cancer control and also for their treatment and care and making sure that patients are put at the center of all the decisions that are taken by governments around the world, and a very strong emphasis on the quality of treatment and care. So an interesting perspective there from Linda. And finally, we have Penny, and Penny, who is a Brit, and she works for McKinsey. She's the head of healthcare, senior partner there, based in Europe, and also has held senior positions in the NHS in the UK, and also is a fellow of the Royal College of Physicians. So we have an outstanding group to discuss this topic. As Alessandro said, we will be taking questions as we go through, and if at the end we have some time, then we'll have more interaction. We certainly have an ambition of having a discussion and a debate, and I would welcome anyone putting a question into the chat box so we can pick them up and answer them a bit later. And on that point, let's start off with a presentation. We will go straight to Penny. Penny is going to do a presentation, the big picture, McKinsey view of the world as it is at the moment in global health and also on cancer control and what we can expect. And then that will prompt a discussion from the rest of the panel. So Penny, thank you very much. I will hand over the lead to you.
Thank you, Carrie, and hello, everybody. Alessandro is very generously going to manage the slides for me, so I will ask him to take us on. Just want to give a quick bit of introduction here. So what I'm going to share with you first is some analysis which McKinsey did last year, essentially in 2019. It was a very big piece of work where McKinsey Global Institute, which works across all industries, agreed to work with those of us who lead the healthcare practice to essentially look at what are the arguments for investing in healthcare. And we wanted to look at this partly through a health economics lens, but also crucially through a sort of wider economy lens, and to make an argument to suggest that spending money on healthcare shouldn't be seen as a burden for countries, but it should be seen as a contributor to net wealth. Because the more that we spend on healthcare, the healthier the population is, and therefore more the population can contribute to GDP. So that's the thesis of our argument. But as I will come on and talk about, it's not about spending money per se. And as many of you will recognize, the money that is currently spent on healthcare is not necessarily spent on the most impactful things. In fact, I don't even have to say not necessarily. I can just state that the money currently spent on healthcare is not spent on the most impactful things. And in addition, the money currently spent on healthcare is not used as efficiently as it could be. So there's a significant opportunity to improve the impact and the effectiveness of current investment in healthcare, but there's also some very good arguments for contributing funding to healthcare in order to improve the health of populations. And that, of course, includes cancer, and I'll come on and talk a bit about cancer. So I will share quite a lot of data. I'll go through it quite quickly because I don't want to hog the whole time. We can come back to some of it in questions. Also very happy to share the material. And then I will finish by talking about how has this picture changed, if it has, as a result of the events of 2020 and the impact that COVID has had. So Alessandro, let's drop down. So I'll go through these first few pages quickly, you'll recognize them. So as we all know, life expectancy has increased dramatically over the last 200 years. You can see a nice drop there, which was the famous flu pandemic of the late 1919, 1920, and so on. And we're now globally at an average life expectancy of 72 years. If we drop down. And the change in life expectancy is different in different countries around the world. And I should have said at the beginning that we've done this analysis globally, but we've also done cuts for high income and low income countries, and for middle income, middle, high, and for middle, low. And again, very happy to share all the detail of that. But a crucial thing is that the quality of life has not necessarily improved, or rather better health is not necessarily improving. So while we are seeing life expectancy go up, we are seeing more people who are spending years in poor health. And that is often related to long-term conditions, particularly increasing prevalence of diabetes, but also some of the other long-term conditions that exist. And you'll see this is particularly stark in the US. So drop down. And crucially, and I have to say, this page surprised all of us working on this, is that the years of life lost to poor health are not necessarily in older populations. We hadn't quite anticipated that. And as you can see here, there's a big chunk of the world's population who are in poor health during their working years. And therefore, this is the crucial bit about if we could improve health, we could have a working age population that are better able to contribute to the economy. Now, you could argue that also applies to people in their 70s and so on, but at the moment we focus on people between 20 and 64. And the amount that we calculate is lost because of poor health in this working age population is a rather staggering amount of nearly $3 trillion. So an enormous amount. So that's the prize that sits here for the global economy. If we drop down. And what is it that's causing this? Now, this is the page that looks very different if you do a different cut for different regions of the world. But if we look at it globally, the reasons for essentially, or if we project forward, the reasons why we end up with people essentially losing healthy years, as you can see here, is particularly cardiovascular diseases, and a big chunk of that is related to obesity, hypertension, and so on, but it's also cancers. And then specifically, we call out diabetes and so on. And as I say, this picture does vary if you look at it in different parts of the world. You also see neurological disorders, just to call that one out, rapidly coming up. And that is because of dementia. So the more that people are living longer years, we're also starting to see more people suffering neurological problems related to dementia. So if we drop down, and crucially, we actually know how to treat a ton of this stuff. And more importantly, we know how to prevent people getting diseases that will impact their health status. And so what we have looked at is we have said, where do we think there are treatments which already exist, which countries should be adopting, which could impact the global burden of disease? And as I will come and show you, these are largely very low cost interventions. So these are things like better immunization rates, more breastfeeding, more focus on smoking reduction, more focus on reducing hypertension, attention to alcohol abuse, and so on. So it's all largely all around prevention and better primary care. And as you will all be aware, those are also crucial factors that prevent people, reduce the chance of people getting cancer. So that is big. That said, there would still be a disease burden remaining, and I'll come on and talk about some of the treatments in the pipeline for that. So if we drop down a page, if we look at those, at the areas that could improve health, what you can see here is that a big chunk of those are the things that I was talking about. So vaccination, childbirth in some parts of the world, and so on. And then there are also, some of them are what we would call traditional medical treatments. So in particular, things like antibiotics and so on. But the crucial thing is a lot of this is low cost, not necessarily easy to deliver, but low cost interventions to improve health. So if we drop down, and this is making the point that this is all low cost care. So if we go to the next page, this is really what are the things that would tackle the remaining disease burden. So we've taken the low cost things, $100 a day, things that would address 40% of the global disease burden. That leaves us with the other 60%. The diseases that make up those are cancer is a part of it, neurological conditions, so again, particularly dementia in there, and then cardiovascular diseases that we don't necessarily have good treatments for yet. But if we go to the next page, you will see, and you will know about some of this, that there's an awful lot of stuff in the pipeline. So the good news is that there are more treatments coming. Of course, what we don't know, we can't tell, is how impactful these will be, what will the cost be, and so on. But we did want to include something in our report, which essentially said we recognise that there are diseases on the horizon, there are treatments on the horizon that would tackle the remaining 60% of that disease burden. So if we drop down, Alessandro, and those would then have a pretty significant impact in actually tackling those diseases. So they're not going to treat everything, and again, I'll come back to dementia as one that we don't yet have a good treatment for. There are some cancers also that we don't yet have cures for, but this is still a sizable impact on that remaining disease burden. So what does this mean? So it means that if we could spend more money, we could have a bit more money on healthcare, we would have a dramatic improvement in terms of impact, which would give us a considerable benefit to the overall state of our populations. Now, this cut is for Western Europe. As I said before, we've done this cut several times. Crucial thing for me, though, my personal interest, is that the way in which we need to spend the extra money on healthcare needs to be in a significantly more efficient way than we spend it at the moment, and targeted on the interventions that we know work. And at the moment, we essentially lose/waste a lot of money by not doing that. So if we drop down a page, and then just to reinforce the point I made earlier, that where does the biggest benefit of this impact? It actually impacts in working age population, but particularly in that sort of latter middle age. So I don't have it included in here, but we do have a page which is that essentially 55 is the new 65. So if we could tackle these common conditions that we know how to treat, that don't cost much money to, we know how to prevent and to treat, that don't cost much money to prevent and treat, we believe that we could add a considerable amount of years to life, and crucially life to years, particularly in that middle age pocket of life. So let's jump down. So that was my sort of very quick overview of the report that we've done, and very happy to come back to that and say to share that. I did want to, though, just flip a bit to COVID. And one of the, I think really, it's obviously been a very difficult year, but one of the real positive things that have come out of this year is that change can happen quickly in healthcare. So I've spent my whole career in healthcare. I've spent the last 25 years in various types of change, trying to get healthcare systems to change and to improve and to evolve. And it's a long haul. It's enjoyable work, it's interesting work, but it takes time. And what has happened in 2020 is that changes which had previously been talked about for 8 years have actually happened in 8 months. Really quite dramatic, the sorts of things that have happened. Now, not all of this will last, not all of this is necessarily positive, but some of it will last. And that should set the stage for saying, how do we really quite radically redesign healthcare going forward? And if we go down to the next page, well, I've given UK examples there are plenty more examples in other parts of the world, because the whole world has had to do this. Now, some countries have done it better than others. We can all see that. But what we have seen very consistently is a big move to digital, a real relaxation of some of the traditional barriers around the workforce, particularly some of the very tight regulations around what different members of staff can and can't do. We've seen relaxation of some of the rules around use of digital technologies. We've seen changes in payment mechanisms that support people to start to use digital technologies instead of face-to-face consultations. And we have seen that it is really possible to really quite rapidly change the face of a healthcare system, importantly. So very exciting that we've seen this. And if we drop down, Alessandro, what is it that we have seen that's really enabled this to happen? So the first is that there has been a much clearer sense of purpose and a real sense of urgency. And you could argue in most healthcare systems, we have been lacking that for quite some time. It's not always very clear to say, well, what's the strategy of this healthcare system? What are we really trying to do? What are the core priorities? And what we've seen in the last 6 months is actually many countries have become a lot clearer. You may not necessarily always agree with it, but they have become a lot clearer. They have attempted to use a bit more command and control, but at the same time allow some local flexibility. And one could argue that that's actually worked moderately well. The third bit is the most important bit, is this real, as I've already referred to, the real innovation in regulation, allowing people to work differently, supporting the use of telemedicine and digital technologies and so on. And as a result, the culture has therefore changed, and it has changed to a bit more of a can-do than a can't-do response. And equally, the last one here is the relaxation of finances has enabled people to move much further, faster. Now, of course, that is not necessarily always sustainable. We are about to enter an extremely difficult, certainly 1 to 2 years, if not 5 to 10 years. And therefore, the way in which healthcare expenditure is used over that time is going to have to be very carefully thought through. So that is the link back to everything I've just been talking about. So drop down. So what is, what could this redesigned, reimagined healthcare system look like? So this is an illustration. It's in some ways not particularly rocket science. You'll all be aware of it, but it's really trying to make the case to say we have to start with the community at the center. We have to start by understanding community health needs. We have to start by addressing the wider determinants of health. We have to have really good focus on prevention, really good focus on primary care, only use acute care where we need to, but crucially make sure the whole thing is joined up, and joined up by using digital technologies, using the things that are available to us in every other aspect of our lives to really help us to think through how do we deliver healthcare in the most efficient and effective way. If we drop down a page, and therefore, what are the things that really matter? This is my final conclusion. First off, let's make healthy growth a social and economic priority. If one thing we have seen through COVID, it is so stark, it is that the poorest populations in society are the most impacted. It is obesity is a massive, massive problem, no pun intended. We have to start tackling deprivation and obesity. The two go hand in hand. We can see it all around the world. It has been so starkly illustrated with COVID, but it links then to cancer, it links to cardiovascular disease, it links to reducing ability, it links to musculoskeletal disease, it links to people not being able to work, and it links to shorter life expectancy. We have to focus on health. We absolutely have to transform healthcare systems, enormous opportunity to deliver care more efficiently and more effectively, and we have to continue with an eye on innovation. So those are my hopes for the future, and very happy to open the discussion up there. Thank you.
Thank you very much, Penny, for taking a very large challenge and presenting it so coherently. I now know when I'm asked my age, I have to say I'm latter middle age. That's going to be my phrase. I wish I was earlier middle age, but I'm not. I'm latter middle age, but that's okay. I'm happy with that. Very interesting you talk about implementing the things we know. This is something which UIC has pushed for many years now, which is like, we have the WHO Best Buys, we have the essential medicines list, we have the essential technologies list. And really there's so much that we can do with generics across low middle income countries, particularly, that it's frustrating that sometimes the debate goes on about the more extravagant solutions when we've got so many things that we can do today with the things that we know, which as you describe, are so cheap. And this is very important in low middle income countries where the financials are not as strong as particularly in Europe. I mean, a lot of that with the work you've done there is around the European model, but you said you've got data for other parts of the world as well. Is that contained in the book? And I know from UIC's perspective, we do have membership all around the world. So I'd be interested to know what data you have available.
Yeah, so most of the pages I shared were global, then with a couple of them focused on Europe. But where they say Europe, we also have similar cuts for different regions of the world. So as I say, all shareable, and I'll make sure that everybody through Alessandra, make sure that everyone has access to that information. Excellent.
And I'm sure people will want to know how to download that. So maybe Alessandra, we could share that with others after the webinar. I noticed Bjorn's on the line as well. So hello, Bjorn. Thank you very much for your partnership. Absolutely appreciate all the great work that you do with us. So thank you very much. Okay, let's move on to Anya. Anya, the floor is yours, really. I mean, you said you may have some other data and some other things to talk about in this space. I mean, it's taking it from global health, taking it into health systems, into cancer treatment and care and cancer control. What are your thoughts about the presentation from Penny and relevance to some of the work that we've been doing?
Thanks so much, Gary, and also big thanks for being invited to this extraordinary panel and also this really exciting series of conversations, which to me really illustrate how we can also use a crisis to find some silver lining here and engage in a very robust, important dialogue across the world around issues related to investments, which of course are part and parcel when we talk about cancer control. I just wanted to quickly mention that, Carrie, you had introduced me as a member of the International Atomic Energy Agency, the IAEA, which is of course true, but very specifically, I'm working here with the Program of Action for Cancer Therapy, which is a partnership with WHO and IARC. And in our mandate, we go beyond just looking at radiation medicine and nuclear medicine. We are in fact providing advisory support to member states in comprehensive cancer control and national cancer control planning and assessments. And then as a next step, we also help them in reviewing opportunities for resource mobilization. And that is exactly where my team works on and where we come in, looking at how we could help member states to generate more resources for much needed cancer control activities, particularly in low and middle income countries. So here I want to thank Penny for this really nice setting the scene presentation on investments for health. And you mentioned that these investments should not be seen as a burden, but also contributor to net wealth. I think globally we have dubbed this conversation more the conversation around an investment case, where we would like to see investments or expenditures on cancer, not just as an expenditure itself, but as an investment into future generations, and also investments that generate massive socioeconomic benefits. And that is the way of how I think we need to take this conversation also forward. What we have seen, of course, is that the aspects that we are focusing on, which is not just the best buys that WHO has put forward for NCDs, but we're actually looking at a package of essential cancer interventions across the globe. This is a package that was developed by the Disease Priorities, the third edition effort led by the World Bank and WHO and also the University of Washington in 2015, which defined an essential package of intervention that spans from prevention, diagnosis, treatment, and palliative care. And in particular also looked at what would it cost to take this essential package to low and middle income countries and provide really access to quality care to everyone in need. So here, just more specifically, this package includes the prevention of tobacco-related cancers. It also relates to the prevention of virus-related liver and cervical cancer, because we have vaccinations available. It looks at diagnosis and treatment of early breast cancer and cervical cancer in particular, and selected childhood cancers, and also includes widespread availability of palliative care, including also opioid drugs, which of course is also part and parcel of the comprehensive cancer control continuum that we've also discussed on earlier conversations, also with the USCEC membership and many others. So here also it is important to note that this approach does not only look at those countries that can afford it, but it also recommends that essential intervention should be invested in across all countries, even for the poorest countries. Some treatment of early stage cancers that involve surgery, drug therapy, and radiotherapy, along with preventive interventions is possible and should be argued for, even if it can only be initially provided at a single center of excellence in a major city. And this, Carrie, here we could actually come back also to the discussion with SICAN and Isabel that you mentioned before. So what would that cost? When looking at this package and the included intervention that I mentioned, this would cost the world an investment of an additional $20 billion per year globally. Or if you translate this would be about 3% of current public sector health spending in upper middle income countries, 5% in lower middle income countries, and 13% in low income countries. So compared to what is currently being spent on cancer, particularly in upper middle income countries, what we know, 3% is actually quite feasible. So we have, for instance, China, Mexico, they spend 2% already. We have Brazil, for instance, they are around 1%. So increasing that with the help of advocates on the ground and also more arguments from the global level is certainly possible. What is not possible is to ask poorest nations to spend 13% of their national health spending on cancer alone. And this is where we actually need global solidarity, and we need to make the case that global investment needs to go into this, and in particular, international ODA here for health. So nevertheless, it is feasible to do if we follow this concept. This is part and parcel of the investment cases. If we follow that concept of shared responsibility, which means that governments themselves need to invest more. And also we need to look for innovative ways of mobilizing more investment in countries themselves, but then also make the argument that there's global solidarity needed that would channel resources, in particular to low-income countries, to provide access to much-needed cancer care. I just wanted to quickly mention a few other very important investment cases that have been developed by the cancer community already in the last 3 years and that have been very successful in their use for advocacy, but also putting the problem out. The first one is the Lancet Oncology Commission and Global Access to Radiotherapy. And here, Mari Gospodarovic was leading this development of the investment case together with Rifat Atun, who participated in the dialogue story series last time. It showed that with additional investment of around $100 billion over the next 15, 20 years, we actually would reap major benefits in terms of life saved. And for every dollar that you would put in, you would generate 4% in return in economic returns. So it is good investment. That's what I'm saying. It's an expenditure now, but then that generates good investment and good benefits and massive health improvements over a long period of time. And then that, of course, also leads to growth in countries and contributes. The other one is childhood cancers. There was a recent publication of the Lancet Oncology report on sustainable care for children with cancer, which has shown that was an additional total investment of close to 600 billion. Over the next 20 years, we would save 6 million avoidable deaths of children. And also global lifetime productivity gains would be 4 times more than what we are asking to put in right now. And there's other reports like this coming. Again, it's very important that you make the connection between investing in the right things, which might not be always very, very low cost. This is something I think these reports have shown, but that would generate massive socioeconomic benefits if invested adequately. So in terms of where's the money, I think we know that, of course, cancer and NCDs and in health in general, global health is actually woefully underfunded. For NCDs, we know that there's only 1.2% of the total development assistance for health is going into NCDs, which of course is quite sobering. We know that there's substantial domestic investment, and here I think actually the poll that you have presented, Alessandro, has shown this. But at the same time, particularly in low and middle income countries, we see very high out-of-pocket expenditures. And then, of course, there's the COVID funding. And here, I think Andrea might also refer to this later, but at the moment, it looks like there are infinite resources that are being thrown at COVID. And a lot of them is actually, the funding is going into health, in particular global efforts like the access to COVID-19 tools accelerator, like the COVAX facility, etc. So they have major investments that we have seen here that have come. And this, of course, poses a number of threats also to other health problems, because some are talking about the potential COVIDization of global health, with an increased focus of global health policy and research on COVID-19 and pandemic preparedness. But also, of course, that might lead to major distortions in health financing also for other diseases, including cancers. At the same time, I believe there's a lot of opportunities that are presenting themselves right now, and we should seize those. And I'm looking forward to discussing those later. Thank you so much.
Anja, thank you very much for that. I think it would be useful if we could share those links for people who may not be fully aware of the work that Mary and REFAT did a few years ago on the economic case for investing in radiotherapy globally. I think that would be useful if you could share that, and we'll get it around to the participants. Just one question for you. You work obviously with a number of governments in low middle income countries, maybe others. And if we ignore COVID for the moment, what do you think has been the major problem with regard to investing in cancer? What are the things that you've heard from health ministers about that? I mean, the case seems to be made. We've seen lots of reports coming out about, invest dollar, you get X back. It makes economic sense. It protects the working population. The economic benefits are strong. So where do you think we've had a problem in the past in convincing governments to invest in cancer control?
So this is a very big question, Carrie. You know that I used to work with UNAIDS for almost 20 years. And I think the HIV community has been very successful in mobilizing global financing and also making the case and putting it out. By the way, I want to mention, because it's World AIDS Day today, I would like to just also say that this is a very, very important event every year. And, there's a lot of activity also around awareness raising, etc. for AIDS even today, which makes, again, the case for increased and continued investment. And that is something that I think where we can learn from the HIV community to some degree. The investment case that I just mentioned was an answer by the infectious disease community led by UNAIDS to the financial crisis 2008-2009, because we saw a major dwindling of financing from donor capitals into health as a result of the financial crisis back then. And then it was very quickly understood that we need to make the case for continued investment, not just saying we need more money, but we also need more health for the money. And that is what Penny related to, basically said, we need to do better. We need to be more efficient. We need to look at being more sustainable in financing. And we also need to be more innovative and use this as an opportunity to present to donors a very clear case that this is really a good investment, especially in times of crisis. For the cancer community, to be very honest, what I've seen is a lot of fragmentation around this. We have not managed to make that argument in a coherent way across cancer so far. And I think there's a lot of room for improvement to really make that as a stronger case, and also advocate it more, particularly also at the national level, the local level, because a lot of the drive around the investment cases also for HIV and then tuberculosis, etc., has more also moved towards convincing governments to put more money into this, and talking to your ministers of finance and your parliamentarians that make financing decisions, and being innovative around it, but also very strong and sometimes not always very good behaved. So sometimes you have to be loud and noisy. And I think there's something to learn also for the cancer community, especially now in times of crisis.
And yeah, that's an important discussion, and probably we'll pick that up at the end when we talk about the things that we can do as a community to make the case. I'm not a man to be angry and noisy, but I can understand that it has value in some situations. But you mentioned the word innovative twice when you answered there, and that's a great segue into Andrea, whose life, I think, has been about creating innovative ways to solve financial issues and challenges. So Andrea, I mean, maybe you could talk a little bit about what blended finance is anyway, and how you and your organization play a role to bridge that gap between the needs of the health of a society and the availability of capital to invest in it. I think everyone would be fascinated to know what you've been up to and what you think about the role that it can play in future investment in cancer treatment and care.
Thank you so much, Gary, and thank you so much to UICC, especially to Alessandra and Carrie, for putting this really great dialogue together. Quite humbled to find myself on a part from the chair all-female panel today. So, and I just wanted to say that Penny and Anya, your presentations, I think, resonate quite well with what I'm about to present. And just to build on what both of you said, you were basically saying you invest in chronic disease or improvement of later stage or middle stage health, and you would see a 2.7x return, right, to the economy. And in my past life before founding the Health Finance Institute, we've come up with similar numbers for the developing countries space, even back in 2011, saying that the world economy loses $47 trillion over 20 years, we fail to invest in chronic diseases, including early detection and care of cancer. And then, and also similarly, when we look at healthcare spending that is flowing into developing countries who cannot afford an extra $50 per year for their cancer care or chronic disease care, I really like the fact, Anya, that you mentioned global solidarity, that there is still a strong case to be made for shared responsibility. And that doesn't mean just leaving countries who do need technical or financial assistance to fend for themselves. So, so for those of you who don't know me, I lead a newcomer organization in global health. I'm currently physically in Austria. That's the organization Health Finance Institute is headquartered in Washington, DC. We work globally as a nonprofit. And we have set ourselves as the goal to develop a blended finance approach and crowd in additional capital into the chronic disease space in developing countries through economic analysis, business cases, and a blended finance approach. So I'm just going to share a couple of slides with you so you know a little bit more who and what we are, and to also hopefully start a dialogue. Can you see my slides?
Yes, Andrea.
Yes.
Now you can see your calendar, I think.
You can see my calendar. Well, that's not a good idea. How about now?
Yeah, I think it's your, yeah, we can see the slides.
Oh. Your calendar has come back again, Andrea, which looks remarkably lean compared to mine.
That's actually, what about now?
Yeah, you're okay.
Okay, great. So, and I moved the slides around a little bit as I was listening to Penny and Anya. And at the core of our thesis and raison d'etre is really that we have seen in the literature and in real life the connectivity between health and wealth. And basically investing in the health of today creates the wealth of tomorrow. And both Anya and Penny, you've backed it up with strong figures. And when we started the organization, we thought, well, why don't we see more investments in chronic conditions, in cancer control, when we know that that there is a strong wealth and health connection? And when we look at blended finance, so in the absence of a Bill Gates, in the absence of really, really strong regulation basis UHC, we need innovative approaches. And more investments will only follow if we connect the dots between who pays and who benefits. So basically, if you're making business and investment cases to private sector, to capital investors, you have to show a link between the particular project and how they would gain either financially or programmatically. So this is what we're all about, that we're forging these partnerships, and we're building not just investment cases, we're building business cases. So our model that we work on is connecting the epidemiology, the economics, as well as the finance reasoning behind why certain partnerships for improving health should exist. So, and just to set the stage, the blended finance is therefore a strategic use of development and public finance to mobilize additional finance towards sustainable development in developing countries. Again, I personally found this quite useful as a depiction, because I think there's a lot of terminology that's been thrown around. So we say, is it innovative finance? Is it results-based finance? What is blended finance? Blended finance sits right in the center of these terms. So development impact bond is a part of that because private capital is involved. Social impact bonds are actually outside blended finance because they usually just are a pay for success model. They're not a bond in terms of market terms. And in blended finance, you see things like first loss capital, advanced market commitments, guarantees, technical assistance, and other innovative instruments. Now, how does a landscape for blended finance in health look like? So unfortunately, and we looked at the track record of 10 years of blended finance funding in development, the health sector portion is only about 6%. And of that, even fewer address entities and even fewer entities exclusively. And for example, I believe HPV and cervical cancer programs are part of it. So you have some cancer programs in there, and I think some breast cancer programs are in there, but it's really, really minute. So for making blended finance work, it will take time, it will take some upfront costs, and it will take partnerships. And I also want to take this moment to call out a really great partnership that we've just started on with the City Cancer Challenge that I believe was also ideated, co-created with the support of UICC, where we will be working on basically educating and working with partners, looking at their specific programs on how they can make blended finance work and help them scale up their programs through blended finance mechanisms. For this presentation, we looked at some examples that exist already in the cancer space where the concept of blended finance is explored. So we found examples of a first loss capital approach. For example, the Nigeria Cancer Health Fund. This is basically a multi-layered solution. That means depending on when a partner starts financing the program, a different risk is taken, therefore also different potential of return exists. And I believe it's also been strongly supported by Roche. I believe they're also on the call today. Then advanced market commitments, and we found one example of Novartis Access, providing affordable quality drugs for NCDs, also including very, very strong contracts a priori, so that as to not supercharge increase the prices of the drugs for people in developing country. Guarantees can include risk reductions, and then obviously technical assistance, but technical assistance in and of itself can level the playing field and also invite additional investments. So we've also looked at why blended finance hasn't taken off for cancer control, as evidenced by the previous analysis I've shown. And it's often we feel that there's a lack of impact reporting and transparency. The incentives need to be spelled out, and there can be high upfront admin costs. So some of our partners say, well, we're not going to invest in anything under $200 million vehicle, but if in order for us to invest in that, we have to show a proof of concept. But if you don't have a proof of concept, we're not going to have such a high priced vehicle. So it's a little bit of a chicken and the egg, and it would really take some pioneers, some foundations, and some companies and governments that take on a little bit more risk and really want to see this through. So what we've been building is we've actually built a model that can help make the business case on top of investment cases. We think that COVID-19 can be utilized as a catalyst, and also to make a case for design stage funding, because there's a lot of volatility that can be explored at this point. So I just want to briefly, we also have sort of a 5-step framework that we follow, that we walk through with our partners. So I'm not going to go into detail in that, but basically it goes from understanding what the burden is and the existence of a protocol to determining the appropriate instrument. And then I just want to caveat that where can blended finance work? So the WHO has released the figure saying about 20% of healthcare funding for chronic diseases, and that includes cancer, should come from the private sector. But they don't really say where, right? Should it be in policy? Should it be in tertiary care? Should it be in primary care? So what needs to happen? Where can blended finance work? It can work where you can prove prevention, greater access, or greater adherence, and direct healthcare savings, basically that delta that immediately derived from that. If you can't show that, you're best, positioned to argue for investing in health for the sake of investing in health and society, for the sake of investing in for greater public good, or making better policies so we have a healthy environment. But blended finance is really a space where business outcomes or capital market outcomes, at least to some degree, as well as health impact, overlaps. So I'll stop right there. And again, thank you so much for the opportunity to share a little bit about our organization and the approach, and also hopefully forthcoming partnerships with some of you on the call.
Andrea, thank you very much for that. I'm sure for many people, the concept of blended finance is quite complicated to understand. And one of the things I think has come out of the City Cancer Challenge, working with cities, is there's an educational role for the likes of your organization and others to help not just governments, but also cancer organization understand how to discuss these opportunities. And I think, that's one of the things, yes, we have to be more vigorous in our pushing for investment in cancer control, and particularly on the treatment side. But I think part of that is a lack of understanding of what options are available particularly in low middle income countries. You mentioned the statistic from the WHO. I've not heard that before, the 20% number. So they're saying that 20% of investment in healthcare should come from the private sector. So again, I think that's an interesting statistic because it's not something I've seen before, but it certainly makes sense. I mean, parts of Africa, you've got 50% of the health infrastructure is actually funded privately anyway, so it's not a surprise. But 20% seems a larger number than I expected to come out from WHO. So if you have the reference for that, I think that would be useful to share with people.
I will share that. I think it was some sort of investment in health, but I'll share it shortly.
Okay, good. And on that investment and the role of the private sector, it's probably wise to move on to our last panelist. Linda works with Pfizer and has a focus obviously in Eastern and Central Europe. So although part of Europe is its own specific challenges, and I'm not too sure if they'd say they're middle income or low income, but we know through cancer there's some real challenges about health infrastructure in that part of Europe. So Linda, why don't you give us some views and perspectives on what your understanding are on the challenges of making the case for investment, given your experience of working in Pfizer. Linda, you're on mute at the moment.
Can you hear me now? Great. Okay, thank you. Keeps muting, so hopefully it stays unmuted. So thank you, Carrie. And for those colleagues on the line, good afternoon. Thank you for the opportunity to share some thoughts. Myself, I've worked in healthcare for more than 25 years, and particularly in Eastern Europe and oncology for the last 12. So I've seen a lot of changes in the region, and Penny's presentation resonated well this morning with me as well, this afternoon, primarily because when we look at, certainly investments in cancer care, the message around not what necessarily we're spending, but how it's being spent is particularly important. Some of the research we've worked and collaborated on in the region has demonstrated that if you look at a colorectal cancer patient treatment costs, and if you look at Hungary as one of the examples, for one patient in Hungary, they're spending 12 times more, around 23,000 euros per patient, where the average in Europe in the WHO designated region is around 1,970 euros. And there are massive differences in those areas. And Mark Lawler, who's been working with us and in this discussion, has discussed, inpatient days. The lack of efficiently used resources is causing some of these increases in let's say, inappropriately used resources. And in one of the areas that we've been working on and collaborating with a variety of stakeholders at Pfizer in Eastern Europe is around the importance of a national cancer control plan. And how can that inform governments, stakeholders, to really make the right decisions and investments in what's going to really bring long-term return as well for patients, but also for a variety of other stakeholders. One of the things we've looked at is how can we develop intelligence that can inform the policy change that's needed. And we're working with some countries. We've recently worked closely with Poland, and we just had a session on Friday with a variety of stakeholders in the Polish government, as well as the designers of the National Cancer Control Plan in Poland, and really using the evidence. And we've helped to collaborate on what we're calling a cancer dashboard. And it's a collaboration of different stakeholders pulling together the data on what is the state of cancer care in a country. We've done them for 18 countries in Central and Eastern Europe. It's mostly based on the available data out in the marketplace, but also some of the specifics around the role of where can the investments be best focused on to bring let's say, the most impactful impacts for patients and for the overall society and cancer environment. This is now starting to get a lot more momentum. We've been working on these dashboards for almost 2.5, 3 years, taking the time to look at those areas that can be enablers of action, so that hopefully not only the countries, but the best practice sharing. So we recently also saw that Croatia launched their National Cancer Control Plan in in January of this year. And what was important, and I think it's very important, is to bring it back to the patient. So as part of the plan, not only was it consisting of oncologists and government officials, epidemiologists and experts, but the role of the patient was very important. And bringing that to, okay, we have these challenges, we have limited resources. How can we advocate for the collection of those resources in a country for a robust national cancer control plan, not only just about treatment, but prevention, detection, palliation, etc. So we've been working very closely in this area because we do believe that investment in healthcare, and we've heard it already this afternoon, the investment in healthcare and also the appropriate treatments. When we're talking about radiation treatment, where we're talking about ensuring that there's a platform for robust molecular testing to ensure that when treatments are utilized, they are going to benefit the patient the best. So these are some examples of what we've been working on in Central and Eastern Europe as an example, but hopefully can help to pool the appropriate resources and then use them in the spending that would be the most appropriate for a country. I think that, unfortunately, we see that around 50%, 53% of countries in Central and Eastern Europe have a national cancer control plan. That doesn't necessarily mean they've been implemented. And I think this is an area that could potentially have a very important impact on resource utilization and also what we're calling KPIs, measurements of the success of those investments on the future. And we know, you probably know better than I, France has a very robust, and they've been able to show over the last 10 to 15 years significant improvements in patient outcomes with their plan. So we'd like to show, hopefully, that those national cancer control plans over the next, and the investment in a national cancer control plan could have similar output and outcomes in other countries similar to Eastern Europe, where the healthcare infrastructure still needs, I would say, significant investment.
That's a very good point that you make. UICC, certainly since I've been around the last decade, we've pushed very hard for every country to have a national cancer control plan. And actually, it's part of that to make sure they understand the investment required to implement it. And then they mobilize the investment to actually make it happen. And we've monitored national cancer control plans around the world. There's certainly a lot more than there were 10 years ago. And a larger proportion of those are invested in. They've got the capital to do it, and they're making a difference. That's the good thing. So from your experience, I mean, if you had to call out one or two countries in the region where you specialize, who do you think has actually done well in terms of developing a plan, investing in that plan and seeing the results? Because those sort of plans are worth their weight in gold for people to say, well, in my country, why don't we have a plan like that? That's so good. That's made a difference.
Yeah, I mean, I can certainly share with you what's currently happening in Russia. So, I mean, certainly Russia implemented their national cancer control plan. They've had a plan for some time, but it wasn't particularly I would say, funded. And the government of Russia has dedicated 750 billion rubles, which is about $15 billion just this year, in the development of their national cancer control plan. Their goals are very lofty. And I would say that they need to probably have an adjustment in their expectations, but their major goals are to reduce cancer mortality by 8.5% by 2024. They want to increase the early stages of identification rate up to 63%. They want to increase the 5-year survival rate up to 60%. And they want to reduce the 1-year mortality rate up to 17.3%. So their goals are quite lofty, but they are very, very focused in their national cancer control plans. Let's see how they'll do in the next 5 years and how they're going to measure it. The Blochen National Cancer Institute, which the major cancer institute is responsible for this plan. So they've put the responsibility with the National Cancer Institute. in Moscow. I think they've done a nice job, and they've brought together a variety of stakeholders to put it together. We don't have the outcomes yet, right? But their goals are very lofty. That's one example. The other is in Croatia. Not as, let's say, lofty goals, but also very structured. And the other is Poland. So Poland only launched their plan this year as well. So they've also partnered with US institutes, other institutes outside of Poland to get input on their plan. So while I don't see yet a lot of outcomes, positive outcomes yet from the plans, the momentum is very important, and the support from the governments and the financing is coming, and that's going to be where I think you're going to see the results. COVID isn't helping. I mean, certainly we had the conversation with Poland on Friday, and they are concerned about the funding that will come in the next 6 months to a year in some of those areas. So we need to watch that space. Russia seems to be still very focused, and I haven't heard, we had a session in Russia recently where they have not had any reduction in their investments for their cancer control plan.
Linda, I was going to ask you about COVID, but maybe I could open it up to the panel to see who'd like to answer another awkward, difficult question. There are views around in the post-COVID world with the governments around the world recognizing that investing in health is investing in the economy, that being for pandemic preparedness or whatever it may be, but health has become not just a health minister responsibility, but a head of state responsibility. And this is good because in the future, health will have a larger role around the table of power in each country. And then there's the contrary view saying, actually what's going to happen is once post-COVID, we're going to get the economic cold shower. We're going to recognize that there's no money left in the bank, in the government's banks. And the first part of the sector that will be hit first will be health. And as it has been done in so many economic downturns in the past. So, I mean, what's your judgment? Maybe Penny, I don't know if you want to answer that first of all, but what's your judgment? Do you feel that, that post-COVID, there will be greater priority on health and cancer will benefit? Or do you think the economic consequences will actually starve health of investment, ironically? Well, where do you feel on that?
So I think that there may well be an increased focus on health, but you then jump to, and therefore cancer will benefit, and I'm not sure that's true. So unfortunately, I mean, there has already been a massive increase. You look at the money that has been spent this year in many countries on health, which has gone primarily on PPE, on testing, on tracing, and so on, as well as money that's been spent sort of propping up economies. It's really, it's a significant amount. If one analyzes it, it works out to, if I did it on UK figures, it's probably something in the order of 100,000, 200,000 pounds per quality adjusted life year. And the normal measure for cancer treatment in the UK is 30,000 pounds per quality adjusted life year.
All right. So you're on the scale of it's going to be okay, but not for cancer, which makes the case for the argument to invest in cancer even more important. Angie, I see you put your arm.
Let me actually, sorry, Kay, let me just qualify what I said.
No, go.
So what I mean is that it has been, for very understandable reasons, there's been a lot of money has been put into COVID-related healthcare this year, a lot of money. It may well be that continues, and it may well be that money continues to be put into testing, lab services, and adding hospital capacity. But we know that isn't necessarily the right place to be spending money for long-term investment in health. So that is my concern, is there may well be a lot of money put in, but it may not necessarily be on some of the most impactful areas that need focus.
Which goes back to your earlier point about we have to be smart investing.
Exactly.
And I think Andrea's model, which is about talking to the private sector, getting involved, there's probably a degree of more smart investing there because they're looking for a return on that investment rather than the social impact necessarily. Anya, I saw you waving your hand at me furiously. So perhaps do you have a view on this?
Not so furiously, but definitely interested, yes. Just the numbers I found was that an estimated 15.99 trillion US dollars has been mobilized to respond to the health and economic impact of COVID so far. So that is a lot of money. What I wanted to mention is that I think there has been a realization that investing in health is a global public good, and that is necessary, and that goes across boundaries. And that's what we have seen now with the investment in access to treatments, but also the vaccine, etc. So that I believe that we will see much more focus also on transnational activities. If you learn from history or look at history, different pandemics in the past have actually led to quite some changes institutionally, but also in the way how we prioritize health. And I think it's very important for the cancer community to be very vocal at this point and very strategic to make sure that you remain relevant to those discussions and changes. Just quickly, how I see this, there are different phases to the COVID response, and we need to be aware of this and then see how we fit in. The first one is the immediate pandemic response, and that is, of course, what we have seen in terms of investing in, in access to protective equipment and access to different ventilators and equipment in hospitals, etc., and flattening the curve as well. Second response, which is already starting, and there you can see a lot of investment, particularly also from multilateral banks, World Bank, etc., is to go into and European Union and domestically is to restore livelihood and mitigate the socioeconomic impact of the crisis. In that part of the response and the phase of the response, I think we can also make the argument that making sure that cancer patients are not being left behind and that the impact on the services, etc., is also mitigated, and we have access to certain support measures as well. And the third one is the Build Back Better. But you have heard a lot about this. This is an agenda which is currently set to bring growth back to a path and actually move it to something that leads to improved sustainability, inclusion, and resilience. And again, if the cancer community is able to make itself relevant to those discussions and show that we have the solutions, then I think we stand a good chance. Thank you.
I think that's very true, and perhaps I can just pick on the Build Back Better agenda, which I think the wording came from like tsunami disasters and things like that, as opposed to dealing with the pandemic overall. But I think it's a great way of framing what we want. We've had one question from Rula, which is about the private sector engagement. So maybe I could ask, Andrea and Penny, well, all of you, what role the private sector in the Build Back Better agenda then? What can we expect from the private sector investment in health, making the capital available? Do you see that there will be more interest in private sector investment in health globally, and specifically cancer treatment and care? Right, Andrea, do you want to start that?
Yeah, sure. I mean, I think that anecdotally, for example, as we engage, HFI engages across governments, international organization, implementers in the private sector, we've heard that because of the pressing need of the pandemic to just find solutions, there was more of an agnostic view to those players who can actually provide solutions, and where, what sector they represented was kind of secondary. And I think that's sort of a welcoming development. And I also want to caution that, we use this word private sector without necessarily delineating what it means and under what context. And I don't have a better term, but I just want to say that it always, people invest in something because they care, and they care for certain reasons and certain motives. So you have to look at where incentives align. So where I see potential collaborations, particularly for cancers, I think in digital technologies, AI technologies, diagnostics, devices, long-term insurance companies for prevention and adherence processes. So really understanding and diving one level below and seeing where do the outcomes and incentives align. And that's then that's the private sector bucket that then understands the value proposition quite well. In terms of I just want to add one comment here about the investments that we've seen into COVID, and $15 trillion is actually quite large. And it has shown that these investments often aren't necessarily made in the health sector directly. They're often made in whatever, paying lost income, lockdown measures and things like that. But when it comes to development assistance, there's actually real worry that the sum total will actually decrease. And I don't think the last word on that has been spoken. So in our analysis, and it makes obviously a lot of sense, I think, to everyone on this call, is the faster you stop the second wave that's going on in Europe and elsewhere, the more you prevent a third wave, the faster you act, the faster your economy will recover. We're looking at 4 to 5% GDP losses in some countries right now, and the more money will be left for health budgets that were originally going to be spent partially on cancer already. So it's kind of this like health wealth connection already in a pandemic response. And I think, not just thinking about building back better, but responding faster so we have more money to go around to keep the economy open, to support, the already planned activities would be my added comment here.
I think that's very true. I mean, from a UIC perspective, we've been 100% supportive of government action against COVID. A cancer patient can get COVID, their family can get COVID. It's been a priority. I think under the Build Back Better, we need to consider the full spectrum of diseases which need to be addressed in the longer term, learning from what we've done on COVID. I'm just conscious of time, just checking on time. So Linda, maybe pass to you. Do you have any, you are the private sector, aren't you? I mean, you're the full representation of the private sector here. But no, seriously, yeah. I mean, you've obviously, I used to work in the private sector as well, and I know it's a massive different group of sectors. But I mean, what's your perspective on this? I mean, from Pfizer, or what you see about investing and getting involved?
I think certainly, first of all, I want to go back to the COVID, if you don't mind. I think when we look at investment, we've seen the data that we're getting around the impact of COVID on cancer treatment, where we see 67% of decreases in cancer screenings, where we see 59% of and we've talked to the physicians particularly in Central and Eastern, but my colleagues all over the globe, serious decreases in the referrals of patients, in the drops in the number of patients that physicians have seen last year versus this. So we need to be careful about let's say the hidden third wave of cancer, let's say in a year or two, when we start to see these patients who didn't get the early referrals or the detection. So the investment will be continually more important. When we think about the private sector, I think certainly at Pfizer, we look at, how can we help provide investment in areas such as education, infrastructure development, and certainly I think that's what we've been doing and working carefully with the right partners in certain markets. It depends, low and middle income countries, but also regions that I'm representing in Central and Eastern Europe, where our funds can go and the investment can go into sustainable investments, building infrastructure that at one point can then be sustainable. And one of my examples is the education of pathologists, of experts in ensuring that the right infrastructures are in place to detect those cancers so that when they do get the treatments, they're getting the right treatment. And I have some examples in markets like Kazakhstan, which is also part of my region, where unfortunately the government made an investment in an innovative treatment, but didn't have the infrastructure to make sure that those patients were getting the right treatment. So we saw a lot of treatment failures, and the investment from that perspective, which is so limited in Kazakhstan, is not going to pay off. So how can we be partners in educating, building the right infrastructure, and ensuring that the investment in innovation is appropriate, but also is then sustainable? So I think that's where we can make a bigger difference, and then hopefully governments can then build on those infrastructures for the future of cancer care in these countries. And that's where I think certainly we can play an important role.
No, that's a great point made there. And we actually had our World Cancer Leaders Summit in Kazakhstan a couple of years ago.
I was there. I was there.
Doesn't time fly? And we're already preparing for the next one in Boston, which
I know.
ironically is all about innovation and how we can
Yeah.
use innovation to address inequity around the world. So we're really looking forward, and hopefully as many of us as can travel to Boston will be there in October next year.
I'd love to be there. Yeah.
One just final point, because I mean, I'm trying to take some questions as they come in, and thank you to others who are answering them. The UICC membership features cancer societies, cancer centers, patient groups, all different groups. And sometimes we forget that many of them are integral to the health system to support cancer patients through their journey, even doing screening, for example. So, and we know through a recent survey conducted by my team that 75% of them have taken a massive hit on their funding because they haven't had the bike rides, the walks, the traditional fundraising opportunities. So I think, we face as an NGO sector a real challenge in the next 2 years to make sure that we're still part of that journey for cancer patients and also the education communities and others. Now, that funding doesn't come from ODA. Sometimes it comes from the government, but more often it comes from the general public. So I just want to flag that, there are some challenges within the health system which cannot be addressed necessarily through blended finance, but we've got to find some way for the civil society groups that's absolutely critical to cancer control in most countries to survive and thrive through the next 2 years. I guess that's my little point, but we're coming to the end. We've only got a few minutes left. I guess it would be great if I could just hand it back to each of my wonderful panelists to do a 1 or 2 minute, well, here's something to think about. And thank you very much for sharing all the documents as well. I know people love those references and they can read them later, but maybe I'll go across the list. Andrea, last views on, making the case for cancer post-COVID, the financial investment. What are your views and headliners that people should maybe think about?
We have a tagline to say, investing in health today creates the wealth of tomorrow. But I mean, I think that the wisdom is really, I think, and Penny, I'm sorry, I'm referring to a chart that you've shown. But I think when you look at, where the disease burden lies that is preventable and amenable, we're really talking middle of life, people that go to work every day, and that we have to really think about investments in cancer as also a reckoning with the quality of life that we support in our countries and globally. So that's my parting thought here.
Thank you very much, Andrea. Let me move over to Penny. Penny, what are your closing thoughts for the 50-odd people who've joined us today?
So I'm a bit of a numbers geeky person, and my view is that we should ensure that all of us continue to put some good fact-based analysis into the whole health expenditure question. So that means we should be spending money on things that matter, and we should be spending that money in the most efficient and effective way. And the more that we can all keep reiterating that, the better for everyone.
And that goes beyond cancer as well, because if it's efficient in one aspect of health system, then it'll make cancer funding more available. So I agree with that. Just so people know, Penny is sitting in a beautiful little town called Salcombe in Devon in the UK. And the reason I know it's beautiful is because I have a house there too. I mean, what a coincidence. There you go. What a coincidence. Right.
We're going to be discussing cancer policy on the beach.
We can indeed. We could go down the South Sands, the Winking Prawn, and have a beer. Wouldn't that be lovely? Anyway, Anya, let's move over to you in sunny Vienna. What are your passing remarks for people on the meeting?
Thanks a lot. Yes, and I'm sitting in a beautiful big building in Vienna, not too far from the Danube, which is also lovely. Anyway, I'm just also, Carrie, I wanted to share a little bit the concern that you've raised around, the civil society engagement and the possibilities and access to financing during the time of crisis. Because as we know, even the fight against COVID, but also cancer is not going to be won in the in hospital wards, in clinics, etc. It's actually won in the front line now, and that is where our community organizations are, and they need they need to, they need to have access to financing and resources. I want to mention that there are opportunities too, and it's something maybe we can think through together. First, really make the case for increased domestic financing, public financing from governments to those NGOs, because again, it is a vital, it's the front line. And, you know, we had people applauding around the globe, but where's the money that is following this? So I think they need to, this argument is very valid. In addition, of course, you know, there's also the argument that I'm trying to do is when you give money for COVID and strengthen the health system, make sure it also benefits the cancer continuum as part of the universal health coverage movement, etc. There is the issue around external financing, and that is ODA we discussed today. Just a few examples. I think we can definitely use the momentum around cervical cancer elimination. This is a global call where, you know, there is commitment and there will be money. We need to make sure that we get access to those funding and financing opportunities that are behind. We need to look at other opportunities, linking it to other disease programs like HIV. I just read the recent statistics on the Lancet that 50% of all cervical cancer cases are linked to HIV in sub-Saharan Africa. So there's a very clear link to also link up with the HIV community and look at funding opportunities there. And that's also what WHO does, is trying to convince the Global Fund, for instance, to fight tuberculosis, malaria, and AIDS, to provide more funding for NCDs and including cancer. There's Gavi, of course, you know, that is relevant for us as well. And a recent initiative that we have started on blended financing is with the Islamic Development Bank and other partners on cervical cancer and breast cancer, which hopefully will also spark a lot of investment of the private sector into a blended financing mechanism, so that we can provide more access also to financing in these areas. And then the innovative financing opportunities. I think the idea around access to a levy, alcohol tax, tobacco tax, certain other duties, etc., should not be off the table, and something that is also to be thought through when going through this crisis right now. Thank you.
Yeah, that's a great list, and I certainly support the increase in taxation on tobacco globally. That will be a wonderful thing that came out of this. Linda, I think we're on you. Last minute or so. Any closing thoughts?
Yeah, I'll keep it. Yeah, sure. Thank you, Carrie. I think certainly the investment in cancer control plans, I think, is something that we should reemphasize, particularly for many of the colleagues, but the countries out there, particularly low and middle income countries that are struggling with those, you know, recommending that we improve cancer intelligence, use the evidence-based approach, so that we can really think about having a policy for affordable, high quality, equitable cancer control. Investing in research, education, and training is going to be important. So investment is not always about funding and in certainly money, but, you know, education, research, yes, it costs money, but how can we do a little bit more of that? We're losing valuable talent in some of these countries as well. So how do we make sure that standardized patient pathways and enhanced capacity building? And let's not forget about the role of the patient organizations. They can help us with promoting healthy behaviors, increasing public awareness. All of these types of investments, I think, can certainly have a positive outcome for patients, but also the future of cancer care for many countries. So thank you so much. Thank you for the time today.
Linda, thank you very much. I'd just like to say thank you to yourself, to Penny, to Anja, Andrea. Alessandro's on the phone somewhere. I can't see him. He's bound to be there somewhere in the background. And also Sinead for help sorting this out. I'd like to thank everyone who joined us today. Finance can be a pretty boring subject, but my word, what an exciting an hour and a half we've had discussing the case for investing in cancer control. So thank you very much to the panelists, my all-female panelists. Thank you very much indeed, and hopefully we'll catch up soon. Thank you very much.
Thank you so much. Have a nice afternoon. Take care.
Bye.
Bye.
Thank you. Bye.